So we are going to transition to a patient's perspective. We've heard quite a bit from the medical field. We've heard quite a bit from doctors, and I think it's time to kind of transition a little bit to hear about how patients, perspectives. And we have Ben Wilson, who is going to just give a brief talk about what his perspective is as a vasculitis patient. Ben Wilson is a sports broadcaster originally from Milwaukee, Wisconsin, and who is currently based in Las Vegas. He does play-by-play for several regional networks, including Fox Sports Midwest and SEC Network. Ben was diagnosed with EGPA in 2014, just before beginning his senior year at the University of Missouri. He started working with the Vasculitis Foundation in 2017 as a youth ambassador and currently helps with development of the Vasculitis Foundation's young adult community. So, Ben, delighted to have you here.
Yeah, thank you. What an amazing intro, Sarah. Great to see you, and yeah, what an honor. I get to follow Doctors Mockett and Dua, who are both outstanding. And yeah, I'm certainly the least qualified medical person here today. But from the patient perspective, though, I did just want to talk for a couple minutes before we bring on Dr. Kermani to talk about steroids in general. And I think as far as prednisone as a whole, it's, I think, at the same time, the easiest thing to talk about in a general vasculitis sense, and also the hardest thing to talk about at the same time, because it's something that impacts us all, but it also impacts us all in different ways. And so it's something that is usually, as Dr. Dewey, you saw all those different medications. I think all of us have been on some sort of combination of those throughout our respective journeys. I've been diagnosed, it's been a little over 6 years now since I was diagnosed back in 2014. But along with that, you're going to be on prednisone and steroids at some point. So the perspective I wanted to give, just talking to all of you here for a couple minutes, is about that and just the impact it has, because there's really, we think about these treatment plans for all the different drugs and the timelines and the amount you're supposed to be on. And the thing with prednisone is it doesn't have any rules. It kind of violates all of those potentially preconceived notions of how long you'll need to be on it, how much you'll be on it, and at what times you'll be taking specific doses. Just for context, for me, I mean, I was on prednisone for 5 years, from 2013 straight through 2017. I was on 80 milligrams at one point. I was on 2.5 milligrams at one point. I was on 10, 20, 30. I mean, you could pick any number. I was probably on that amount of prednisone at one time or another. If you would have seen me back then, you would not recognize my face, because I, like many of us, gained quite a bit of weight in the moon face, as we like to call it. But it's something that I think from a mental perspective, and Dr. Mockett certainly touched on this a little bit. As you go through it, I think the most important thing is, as far as steroids are concerned, is to remember that, as we look at all these different medications, kind of this big equation, trying to combine to find the best outcome and best result for how you're feeling as the patient. And you'll likely have your team of doctors who are weighing all those different factors and trying to figure out what the best solution is. But I think the thing to remember with prednisone is that ultimately you are the quarterback of your entire team. And prednisone, I think, while it is obviously a drug that has a lot of harm, obviously also does a lot of good. And while it can fall at times into that necessary evil category, it can also teach you a lot about understanding and learning your own body, how you react at different points where you're on as far as your treatment. I mean, you can feel a mileage of difference from even being on 10 milligrams of prednisone versus 8 milligrams of prednisone. It's amazing how big a difference you can feel with just a small change in your dosage. So the thing for me, in my own experience, I just remember how, thinking about it from my parents, my team of doctors, we were all so concerned about those long-term impacts. And Dr. Kermani will get into this a little bit more, because there are obviously those long-term side effects that can be really damaging. And it's why we ultimately want to get off prednisone, and it's a huge milestone if we can. But I remember at the same time having such an urgency, such a desire to completely get off prednisone, that you can sometimes lose sight a little bit of the fact that it is a really long process. It's not something that you can just be on for a few days or a couple of weeks and just all of a sudden, boom, you're off and you're good to go. You're back to being 100% again. it's something that it does take time, and it takes the ability of you as a patient to listen to your body and then relay that to your doctor. Say, hey, this is how I'm feeling at this particular rate of prednisone. I definitely had, on more than one occasion, I tried to, on my own, speed up that process of getting off prednisone, because I kind of had this thought ingrained in my head of, all right, this is an evil drug. We can't be on it. We're going to have all sorts of terrible things happen to us. And what instead happened was I went off probably too early and would end up having flares and relapses and a lot of the even worse symptoms of my own vasculitis, having an EGPA diagnosis come back. So as I've gone through it, and like I said, having been on just about every type of a type of amount of prednisone over a 5-6 year period, I can tell you that it is one of those things that really forces you to take as detailed and introspective of an approach as you possibly can with your own body and how you're feeling. Because no matter what sort of treatment you're on, whether, for me, with all the ones that Dr. Dua mentioned, I started off on Cytoxan, I've been on Imuran, Cellcept, I'm on mepolizumab now. But no matter what, you're going to be on some level of steroids, and it's going to affect you on a day-to-day basis with how you feel, from fatigue to the moon face, of course, and general other factors as well. So my biggest advice, just from going through this and having my own perspective, is make sure, like I said, to be that quarterback of your whole medical team, and kind of learn to really communicate your feelings based on that direct impact prednisone is having on you. And at the same time, I used to think having to bump up prednisone, having to go back on a burst, going back up to say 40 milligrams a day to get my symptoms under control. I thought that was like an admittance of failure, and that we were going back to square one, and that we were kind of going in reverse, trying to drive toward that light at the end of the tunnel. Just understand that from a mental perspective, that's not really the case. We're, as vasculitis as a whole, it's a disease and a journey as a patient that has all sorts of bumps in the road, and it's never really going to be a straight line. So don't get discouraged just because you have to maybe go back up on your prednisone dose, or just because you're starting to see a lot of other symptoms. Maybe you look in the mirror, you don't really recognize yourself one day. Just know that we've all been there as patients, and that's an extremely common thing. And so while you don't want to become in a situation where you're relying on prednisone every day and just popping 20 milligram pills, having them in your back pocket. I may or may not have done that at one point as a college student, just trying to have fun. Well, obviously you don't want to go that far to the extreme. Also understand that if there's times where you're not feeling well and you can feel symptoms starting to come back, make sure not to ignore that feeling in your own body, even as you understand that ultimately our goal is to get off prednisone, but know that it can be that necessary factor that you require. So that's just a little bit of my own perspective. I know Dr. Kermani has a much more in-depth medical perspective on that, and can tell you more of the specifics. I just know that from a patient, and from every other patient I've gotten to meet through the VF, and there have been quite a few of them since I've been really fortunate to get to work with this organization here for the past few years. I know it's something that's common to all of us, and no one treatment is the same. So I hope you can just sort of keep some of those things in mind as you start your own journey, and understand that that light is going to be there at the end of the tunnel, no matter what sort of symptoms you're feeling or how much prednisone you have to be on. So I'll kick it back to you, Sarah. Thanks for all you've done with hosting this today.
Absolutely. Yeah, Ben, thank you. Thank you. I mean, I agree 100% with everything that you said there. I mean, everything you said I've experienced. And it's funny, I once heard prednisone described as the duct tape of the vasculitis world. It works, but it ain't pretty kind of thing. And it works. It ain't pretty, but it works kind of thing. And, it is part of the arsenal that we have. So absolutely. Thank you, Ben. Thank you.
Thank you.
Great
Appreciate
seeing you.
it.
Take care.
Thank you.
So, as Ben mentioned, we are going to be hearing about steroids 101. And presenting now is Dr. Tanaz Kermani. Dr. Kermani is the founder and director of the Multidisciplinary Vasculitis Program at the University of California, Los Angeles. She grew up in Mumbai and moved to the United States in 1996 to pursue higher education. She completed her training in internal medicine rheumatology at the Mayo Clinic in Minnesota and joined UCLA's Health Division of Rheumatology in 2012. Dr. Kermani sees patients with all rheumatological diagnoses and has a special interest and expertise in vasculitis. She completed additional training in vasculitis at the Mayo Clinic as part of a prestigious Vasculitis Clinical Research Consortium Fellowship. She is an active member of the vasculitis research community with multiple ongoing national and international collaborations with vasculitis patient advocates and medical experts. She has published several vasculitis research studies. So without further ado, Dr. Kermani, I'm going to hand it off to you.
Thank you, Sarah, for that very kind introduction. And thank you, Ben, for setting the stage for our talk today. This is one of the challenging topics is putting people on steroids. And I want to say that as physicians, we try to be responsible because we do know about all of the side effects and the impact that it can have in our patients' lives, but it's also a necessary evil, as you heard about. So I have no disclosures. So what I'm going to set up talking about is first about why we use steroids in vasculitis, and then the dosing of the steroids in vasculitis. And then, of course, we're going to talk about the side effects, which as patients who have taken steroids, you know better than I do, but also how to manage them. So, as you know, vasculitides encompass a group of autoimmune conditions which are characterized by inflammation of the blood vessels. And with inflammation of the blood vessels, the organs that these blood vessels are supplying get lack of oxygen and blood supply, which causes damage to them. So our treatment is directed at suppressing the immune system to manage the inflammation. But our goals when we're putting people on treatment, both the steroids, but also the other treatments that Dr. Dua talked about, is to decrease the inflammation and prevent further damage to the organs. Of course, to achieve and maintain remission, sometimes the maintenance of remission is the more challenging part as well. Treating flares, as Ben talked about, there are ups and downs in most of the forms of vasculitis, and then always monitoring for the safety of these medications and side effects as well. So a brief history of glucocorticoids, which are the steroids that we use in rheumatology. The picture on your right is Dr. Hench, and then on the left is Dr. Kendall. Dr. Kendall was an endocrinologist at the Mayo Clinic, and Dr. Hench was a rheumatologist at the Mayo Clinic, and actually the founder of the division of rheumatology there. And Dr. Kendall, the endocrinologist, had identified compound E, which was, he found beneficial in people who had Addison's disease, which is characterized by a deficiency of cortisol. So people get symptoms like fatigue, low blood pressure, myalgias. And Dr. Hench, the rheumatologist, realized that some of these symptoms were also experienced by patients with rheumatoid arthritis. So he used cortisol in a patient, a 29-year-old woman with long-standing rheumatoid arthritis, which was severe and who was wheelchair bound. And the effects were miraculous. Within a week, she was out of the wheelchair, walking. Of course, later on, we realized some of the side effects of the medication, but this was one of the first uses of steroids in rheumatology. In 1950, both of them received the Nobel Prize in Physiology for their discovery regarding cortisol. So in 1950, they received the Nobel Prize, and then here we are 72 years later, and the steroids are still being used in the treatment of many of our inflammatory conditions, but particularly vasculitis. So some of the basics, the adrenal glands are the glands that sit above the kidneys, and they secrete hormones that regulate the immune system, blood pressure, but also our response to stress. And there's two parts of the adrenal gland. So there's the cortex, which is that light brown area on the outside of the adrenal gland. And then the deeper brown with those little blood vessels in there is the medulla. And the cortex produces cortisol, aldosterone, and some of the other hormones, whereas the medulla produces epinephrine and norepinephrine, which are our stress hormones. So cortisol, which is produced by the adrenal glands, are regulated by the pituitary, is regulated by the pituitary and the hypothalamus, which are in the brain. And there's a feedback loop that goes from the adrenal glands to the hypothalamus and the pituitary. And our normal body in normal conditions, our body produces anywhere between 5 to 30 milligrams of prednisone a day. And on the right here, you see a curve. So the peak for prednisone is in the morning, usually about half an hour after we awaken. And then you can see as the day goes on, the levels of cortisol start to drop. And by midnight, it's almost undetectable. So this is important because physiologically, most of the prednisone peak is in the morning, or the cortisol peak is in the morning, which is why you want to take the medication in the morning. Also important to note is that under normal circumstances, if we have infections, stress, our body produces more cortisol. So that's important when we talk about some of the side effects of steroids and why not to stop it suddenly, even if you have infections. So the glucocorticoids are steroids. We're using them for the initial treatment of almost all types of vasculitis. There's several ways we can administer them. One is through the vein and then also by pill. And there's different formulations, but the ones that are used in rheumatology are prednisone and sometimes methylprednisolone or Medrol. So why steroids? Despite all of the side effects, why are we still using these medications? So the key is really that they are very potent anti-inflammatory medications and also effective at suppressing the immune system. And the most important part is that they work quickly. So our other medications like the methotrexate, azathioprine, some of the other ones we discussed take several months to work. And of course, in something like vasculitis, where you're having organ damage from inflammation, we don't have the luxury of waiting months for these other medicines to work. So that's really the reason that this is still a cornerstone in our treatment for vasculitis. Of course, regular follow-up is important because we want to evaluate that the medications are working, assess how quickly we can lower the medication like the steroids, and then also monitor for side effects. And as Ben mentioned, you are the quarterback. So if you're having troublesome side effects, notify your doctor. Just please don't stop the treatment abruptly. One, because it can be dangerous and cause shock because the adrenal glands may not kick in to produce cortisol, which your body needs if you've been getting steroids for a while, but also we don't want the disease to flare and become unmanageable. So the IV steroids we usually use in what we call initially as quote induction end quote for doses varying from 250 to 1,000 milligrams that are given for about 3 to 5 days. That's kind of to put out the fire, manage the inflammation, and then if we were not to do anything or put people on oral prednisone, then things would come back. So that's why after the steroids, usually you have to go on oral prednisone. On average, for most of the forms of vasculitis, the dose is 1 milligram per kilogram per day. We don't typically go above 80 milligrams. That dose is held sometimes for up to a month and then a slow taper over several months until you get to very low doses, if possible, off the prednisone. And again, the taper is not set in stone. We use this medication in different ways. If people are doing well, the taper can be sped up. If people are having a lot of side effects, again, these things can be reassessed, but it's important to work in partnership with your doctor. And the only way to move things along is actually to notify them if you're having side effects, and then work as a team to decide on the safest course. Also, the side effects depend on the doses of the steroids and also how long you're on the steroids. Definitely higher doses, longer duration of treatment, more side effects. By definition, high doses are anything above 30 milligrams. The medium doses are 7.5 to 30 milligrams, and then low dose is 7.5 or lower. But typically, once you get to 10 milligrams or lower, I would say the side effects start to diminish, although they're not zero. It's also important to note that some of the side effects are reversible while others are not. So effects like the bone health are not reversible, whereas some of the weight gain and other changes are at least mitigated by lowering the dose. Oftentimes, because of the side effects of the prednisone, you are also put on other medications. The common ones that we use are medications to protect the lungs. There is an opportunistic infection called pneumocystis, which is a fungal organism that can cause bad pneumonia in people who are immunocompromised. Bactrim is one of the common antibiotics. It does not protect you from every infection. It's just to treat this, to prevent this particular form of lung infection. If you're allergic to sulfa, sometimes we'll use things like dapsone or atovaquone. In cases where people are having a lot of stomach issues from the steroids or have a history of ulcer, we may also add antacids to protect the lining of the stomach. To protect the bones, it's important to take calcium. We always prefer dietary source if possible, and then also vitamin D, because the steroids affect the absorption of calcium and vitamin D. And if you're deficient, they start breaking down the bone to get the calcium and vitamin D. So that's an important thing to protect your health, bone health. Sometimes if you have thin bones or osteoporosis, we might also use other medications to protect the bones. It can be overwhelming, of course, when we're adding the prednisone with the taper and then all these other medicines on board as well. But just remember, some of these things can be discontinued as you lower prednisone, or once you discontinue prednisone use. It's always important to bring it up with the doctor and reassess which medicines are really needed. So the side effects, which are listed here in many, these are some of the ones that do improve as we lower the prednisone. Increased appetite, weight gain, fat redistribution, where it distributes fat to the back of the neck or over the shoulders, the puffy moon face, which is really bothersome because it changes how you look, obviously. Water retention, flushing. There's also a lot of side effects on the skin with easy thinning, bruising, tearing. Sometimes people, if they gain a lot of weight suddenly and then as they lose the weight, they can get the stretch marks or the striae, the tremors, muscle weakness, muscle cramps. Sometimes the magnesium, potassium, assuming you don't have any kidney problems, or hydration can help with the cramps, which can be very bothersome as well. And of course, sleep disturbance and mood changes, which can vary anywhere from depression, anxiety, sometimes to mania or a lot of energy as well. The other side effects, infections, which we'll talk about in more detail, effects on the bone, which I already mentioned. So it can thin out the bones and cause things like osteopenia or osteoporosis in people who already have thin bones. It can thin them out further. There's a rare side effect called avascular necrosis, where for some reason the blood supply to the bones can get cut off in people who are on steroids. That usually presents with pain in the joint. The most commonly affected areas are the hips, knees, shoulders, but any area can be affected. So if you have new unexplained joint pain, that's something to bring up with your doctor as well. It can cause metabolic side effects like high cholesterol, diabetes. Sometimes the diabetes is also exacerbated by weight gain related to the steroids. Stomach issues, which we discussed, elevated blood pressure. So this is something that we need to keep track of as well. The adrenal glands we'll talk about in more detail. And then side effects related to the eyes, like cataracts, glaucoma. Sometimes it can cause a lot of fluid or swelling, something called central serous retinopathy. So the key is, of course, lowering the steroids when possible safely, but there are also strategies that you can do to help manage some of the side effects of the steroid. The first one is taking it as prescribed, usually in the morning. As I showed you in that curve, our body naturally makes a lot of cortisol earlier in the morning, and then the levels taper out in the day. There are some times where the doctor may ask you to split the medication, either because you're having a lot of the side effects or they feel like the effects of the steroids are wearing off too early. In that case, it's better to take the second dose either in the afternoon or early evening. You really don't want to take it around bedtime. It can disrupt sleep. And also, that's not your normal physiologic peak of steroid. Dietary factors, easier said than done. but prednisone can really trick your brain into thinking that you're very hungry. It can make you have cravings for unhealthy food. The best thing is to keep healthy things around you that you can snack on rather than keeping junk food around within access. It's important to minimize sugars and then also monitoring carbohydrates, both in terms of the weight gain, but also in terms of the increase in sugar and diabetes, which usually is related to diet as well as the weight gain from the steroids. Important to monitor salt in the diet. This can help with some of the side effects like the high blood pressure and the swelling, because with the salt retention from the steroids comes fluid retention. So also fluid restrictions, especially in people who already have baseline kidney or heart problems, either from unrelated causes or from vasculitis. These can all help. And again, some of these things will improve as we get to lower doses of steroids. Activities, again, this can be challenging depending on what's going on. Many of our forms of vasculitis can affect the nerves and affect strength, ability to walk. So whatever activity you can tolerate, usually gentle weight-bearing activities if possible. If you're having issues with weakness related to the vasculitis and nerve involvement or muscle weakness, physical therapy can also help. And then we do have medications that can help with pain, sleep, anxiety, depression. Again, it's challenging because we don't want to keep adding more and more medications, but if needed temporarily, again, discuss the side effects you're having with your doctor, and there are ways that we can manage some of the side effects, especially when you're on the higher doses of the steroids. Sometimes things like mindfulness, meditation practice can help with the side effects, including sleep disturbance. And if you're still having problems, or of course, even if you're having any side effects, these should be brought to the attention of your physician. But if you're having difficulty to a point where you're contemplating just stopping the medicine or the side effects are getting bad, then again, discussing with the doctor a quicker way to lower the prednisone, but also making sure it's safe. That may be just monitoring you more closely, doing labs more frequently to make sure that the vasculitis is not flaring. But there are ways to maneuver around a lot of these side effects. The other important side effect is infection risk. Even before COVID-19, all of our patients who are on immune suppressing medications were given these simple precautions. The risk is again high on the higher doses of steroids, but it's not zero, even once you get to lower doses of steroids. Of course, you want to avoid sick contacts, not always possible if that's someone you're living with. Good hand hygiene, hand washing, which is very important, especially now as well. It's very important to get all of the appropriate vaccinations, including the annual flu vaccine. The only vaccines that are not recommended are live vaccines, and even the shingles vaccine, the new one, is now an inactive vaccine, so that's something that our patients can get. Reporting signs and symptoms of infection immediately are also very important, while also recognizing that people who are on high doses of steroids or are immune suppressing medicines may not mount a typical fever response, or the intensity of some of the signs of infections like pneumonia may be blunted because of the medications. So even a low-grade temperature in someone who's immunocompromised may be of significance. So again, if you have any signs or symptoms of infection, contacting your doctor to get evaluated, and also make sure you don't need to be on antibiotics. And then even if you have infection, this is a medication you do not stop suddenly. Again, during periods of infection, our normal physiologic response is to be on create more cortisol. So this is not a medicine you want to stop suddenly when you're sick. The adrenal insufficiency, which I alluded to. So again, the adrenal glands are the ones that produce the cortisol, which you're getting in the form of prednisone while you're on the medication. It's one of the reasons that we lower the medication slowly rather than stopping it abruptly. And some of the symptoms to monitor that may suggest adrenal insufficiency are fatigue, beyond, more fatigue than, because a lot of our patients already have baseline fatigue, but especially more fatigue, muscle pain, lightheadedness, nausea. Usually these symptoms occur just as you've lowered the dose of the prednisone, so that can be one of the clues. Sometimes it can be very difficult to figure out whether the vasculitis is acting up from lowering the steroids or whether this is actually adrenal insufficiency. Testing and monitoring other symptoms can help sort this out. Sometimes we have to do more testing to see if the adrenal glands are working. Sometimes we'll have our endocrinologists on board to help with that. And if people are still having a lot of difficulty tapering off the steroids because of adrenal insufficiency and not because of the vasculitis, again, at that point, we'll usually have our endocrinologists help. There are different formulations of steroids that can be used to help with the adrenal glands and to taper off the steroids more gradually. So to summarize, at this point, from the perspective of the vasculitis and inflammation, the benefits of these steroids still outweigh the risks in vasculitis. We try to use the lowest dose needed to manage disease activity, but also while waiting for some of these other medicines to work. It's important to follow the instructions, but it's also important, this is again, moving goals, so or moving targets, so it's always reassessing. So if you're having side effects, just bring that to the attention of the doctor and we can help. And Dr. Springer is going to talk about newer strategies to minimize or even avoid steroid use in patients with vasculitis. And with that, I thank you for your attention. And any questions?
Dr. Kermani, thank you. That was just incredible. So thank you very much for the broad and also very specific discussion around steroids. So thank you, thank you, thank you.